Everyone, welcome back to another Intimate Rose specialty webinar. Today, I'm going to be talking about vulvar and vaginal moisture. So we're calling this Vulvar and Vaginal Moisture 101. So I'm going to go a high-level overview of different conditions. I'm going to go over different treatment methods and the populations that we see in clinic that are going to benefit from using these types of products. I'm going to go ahead and share my screen here. And we will take it from the beginning. Welcome to Vaginal Moisture 101, supporting lifelong health with lubricants, balms, and hormone therapy. I am Amanda Olson. I'm a physical therapist specializing in pelvic health for the last 16 years, and I'm the president of Intimate Rose. As a reminder, before we get rolling here, is that we have so many different avenues of support here for you as a clinician and also for patients. If you are running low on brochures that have your discount code on it for patients, please don't hesitate to reach out to support@intimaterose.com. We are happy to get them to you. Additionally, if you don't yet have some of the products from Intimate Rose that I'm going to go over today, we are happy to send them to you as samples. We have samples of our amazing water-based lubricant, and we can send you a jar of our vulvar balm as well to help patients feel it and experience it, which I know is helpful. And then additionally, this is just one of many recorded online continuing education courses that we offer. We have a full library now. I think I have 12 other courses there. They are 1-hour courses. They are free, and we offer you 1 hour of continuing education for them. So you can see the link here to go to the network. If you go to the resources page there, you'll find that library. Additionally, you will find printable PDFs of tools guides. So printable PDFs on home exercise programs for patients on the dilators, the wands, the anal dilators, all of those amazing tools. Our learning objectives for today are that you will comprehend hormonal changes that result in vaginal dryness, that you'll comprehend 3 potential management strategies to help patients address vaginal dryness. So thinking very broadly about vaginal moisture 101, it's important for all the vaginas, but particularly giving care to our postpartum patients that may be experiencing a low estrogen state, and they might benefit from a topical estrogen cream from a prescribing provider. Those that are in perimenopause that might have more different forms vaginal moisturizers available to them, including topicals and hormone therapy. Our menopause population for ongoing maintenance of their vaginal tissue, and also paying special attention to the med list. Patients that are taking different medications may be experiencing side effects that include vaginal dryness that doesn't get addressed with their provider sometimes. And sometimes they go long periods of time and it's really affecting their overall health and their sexual health. These include oral contraceptives, aromatase inhibitors, which is one of the medications used to treat breast cancer, antidepressants, antihistamines, and anti-estrogen medications. And additionally, those with autoimmune disease that may be taking other medications, but also sometimes the side effects of that disease process can result in some vaginal dryness. That definitely includes Sjogren's syndrome. And then with endometriosis, that's an autoimmune disease, and they may be taking different medications to address the inflammatory process and the pain they're experiencing. And in some cases, that can leave them with vaginal dryness as well. So zeroing in on GSM, or genitourinary syndrome of menopause, this is a collection of symptoms and signs associated with decreased estrogen and other sex steroid levels that can include changes to the labia, clitoris, vagina, urethra, and bladder. This term includes symptoms associated with menopause affecting the vaginal area as well as the lower urinary tract. So keeping in mind that all of those structures are stacked closely together. We have urethra, vagina, rectum here with the pelvic floor muscles supporting all of it, and then the organs sitting above. I'm going to dump the organs really quickly here. But when we think about the proximity of the bladder here, the vagina right behind it, and then the bowel here, we can see those organs are just 3 tenants in a small, that is the pelvic bowl here. So changes that affect that vaginal tissue can irritate the bladder. Likewise, bladder issues can irritate that vaginal tissue. Constipation in the back can certainly impact and affect that vaginal tissue as well. So we want to be asking questions subjectively of our patients concerning all of those organs. Symptoms of menopause. According to the Menopause Society, there's something like 38 symptoms that are recognized now as a byproduct of the hormonal changes and shifts that happen during menopause. This includes certainly changing periods, decline in fertility, night sweats and hot flashes, GSM, genitourinary syndrome of menopause, vaginal dryness, thinning of the vaginal tissues, shortening and tightening of the vagina, pain or burning with urination, urinary incontinence, urinary urgency and or frequency, sleep disturbance, joint pain, adhesive capsulitis or frozen shoulder. That one should stop us all in our tracks. Joint pain is really common in this patient population, but additionally, I remember learning in PT school something like 20 years ago that adhesive capsulitis was more prevalent in postmenopausal women. And I remember thinking, what in the heck? Why on earth is a shoulder issue related to menopause? And it is because there is changes systemically throughout to these tissues that makes them really tight and it can make them shortened. And that results in changes from the shoulder down to the feet. So we want to make sure that we ask questions too, just about how they're, if they are experiencing any joint pain or loss of range of motion, because those patients definitely also need to be seen by orthopedic physical therapists, possibly an occupational therapist, and perhaps an orthopedic physician as well. And then mood changes, memory problems, weight gain, and changes in weight distribution. Certainly none of these are fun. The scope of our talk today is to talk specifically about that vaginal dryness, but I wanted to include all of these symptoms because they all can interplay with each other, and using hormone therapy to address vaginal dryness, if it's applied systemically, can help address all of these other symptoms as well. So I wanted to include that as part of the dialogue. We're filming this on November 12th, 2025. Yesterday was a really magical day in the world of vaginal dryness and hormone therapy. The black box warning was removed from vaginal estrogen about all of the claims regarding cancer and all of those other deterrents to patients wanting to seek hormone therapy, topical estrogen, and to providers wanting to provide it and write prescriptions for it. So big day today. And here we are getting to hopefully experience a new dawn of providing patients with the care that they need and deserve, and specifically highlighting the effects of local estrogen on that vaginal tissue to improve moisture and flexibility, help address some of that thinning and dryness and shortening and tightening of the vagina. With regards to shortening and tightening of the vagina as well, certainly vaginal dilators are a helpful tool to improve mobility, to regain some length and width if they've lost that throughout their menopause journey. And those can certainly be helped with a provider of pelvic health therapy, physical therapy, or occupational therapy. Thinking about the role of estradiol on sarcopenia. So thinking about a little more broadly again about muscle health during menopause, a progressive muscle degeneration, including decrease in quality and muscle function occurs. This is important systemically throughout the body. I talked a little bit about the shoulder and adhesive capsulitis, that's specific to the joint. But when we're thinking about quality of skeletal muscle, guess what is made of skeletal muscle? The pelvic floor muscles. They are muscles just like everywhere else, and they are susceptible to changes due to low estrogen states in quality and in function, and that can result in some cases in a new onset of urinary incontinence or pelvic organ prolapse. Maybe it's also resulting in a decay in their sexual satisfaction, both on the dryness side and on the pelvic floor muscle responsivity side as part of that orgasm response to stimulation. So important for a lot of different reasons. But this muscle dysfunction is caused by decreased proliferation in muscle satellite cells, increased level of inflammatory markers, and altered levels of sex hormones, which exposes people with a vagina, these women, to a raised incidence of sarcopenia. This is just a little diagram showing this overall effects of aging around perimenopause and menopause, where we have this sarcopenia onset. We have an increase in inflammation, increase in visceral adiposity, so that relocation of fat that I touched on, decrease in satellite cell proliferation, so they're not turning over the same way that they used to be, decrease in muscle mass and strength, and then decrease in bone density. This little chart here compares men to women as we age. Here's our lady here in the middle. We see with regards to bone mineral density, she's experiencing peak bone mineral density between the ages of roughly 20 and 30. And then it's just this wee downhill slope throughout the rest of her life. So adorable, isn't that? So this is why we want to be screening and ensuring that our patients are getting adequate hormone therapy from their providers, that they are, because that can have a benefit to not just the vaginal tissue itself, not just the bone mass, but also bone mineral density and the muscle mass and strength. And just another highlight that it's significantly less than men. Okay. Looking at the effects of menopause on overall body composition, a cross-sectional study analyzed pre versus perimenopausal women where similarities between the groups were observed for lifestyle factors, including physical activity and diet. So these are pre-menopausal and then peris, and they've got the same level of activity and similar nutritional styles. They looked at body fat percent and they found it to be significantly lower in the pre-menopausal than in the perimenopausal group. Again, same lifestyle factors. They also found fat oxidation during moderate intensity cycle ergometer exercise significantly greater in the premenopausal than in the postmenopausal women. And change in respiratory exchange ratio between rest and moderate exercise was lower in the premenopausal. So these women are able to exercise at a better intensity with better fat oxidation. They were able to recover greater. So these are just some displays of the role that the hormone shifts have on overall physiological well-being as well. So looking a little closer then at menopause hormone therapy, MHT, or hormone therapies as it's more commonly being referred to now, so HT. Hormone therapies are the prescription drugs used most often to treat menopause symptoms such as hot flashes and GSM, which includes vaginal dryness after menopause. And it replaces the female hormones, including estrogen and progestins, lost during the menopause transition. And it is FDA approved as first-line therapy for the relief of hot flashes and is shown to be the most effective treatment. Additionally, benefits particularly outweigh the risks for hormone therapy when used in early menopause to relieve the vasomotor symptoms, which include those hot flashes and night sweats and the sleep disturbances. So when we're thinking about this, we're thinking about the role that it plays not just on the vaginal tissue again, but more broadly speaking. And again, on the heels, when I made this slide deck, it was a couple weeks ago. So it wasn't even at this new dawn, as I mentioned, of removing some of the risks associated with that vaginal estrogen. And certainly every patient should be having a conversation with their prescribing provider about what is appropriate for them, because certain patient populations do certainly have higher risks if they have had breast cancer themselves, or if they have had cervical cancers. They need to be considered differently than those that don't have any of those risk factors. So some types of hormone therapy broadly includes systemic therapy and then topical or low dose therapy. So systemic therapies are those that when hormones are delivered throughout the body, these come in the form of pills, patches, sprays, gels, or a vaginal ring. And this is known as systemic therapy. And they're absorbed into the bloodstream at high enough levels to have significant effects on the widespread areas, again, addressing those vasomotor concerns, hot flashes, and also on the muscle and bone health. And then the local topical low dose therapy is also called vaginal estrogen therapy, and it's administered directly to the vagina. It's effective for both moisturizing and rebuilding tissue. Very little goes into the bloodstream, so the risks are far lower. It's very, very centered on the tissue that it's acting on. So methods of use include a pill, which can be taken daily, generally easy to use. There's patches, which can be applied to the skin, delivers a steady dose. And then there's gels that can be absorbed through the skin, allowing flexible dosing that can be done on the inner thigh, abdomen. And so for patients and providers, it's just good to have a conversation about how the patient is best going to slide this into their daily routine or their weekly routine. And then also with regards to the skin and absorbency, when we think about the patch, it's important to ask questions about, does the patient have really oily skin? Like how well is that patch going to stick for them? Are they going to forget to take a pill daily? If they are one of those that sets an alarm and they're really good at daily taking that pill, then they could be a good candidate for that. If they'd rather have the patch, something they don't have to think about as much, they set that reminder for a weekly or biweekly or whatever program that they're on, or if they'd rather just have the gel and apply it themselves and not have a patch on their skin and not have to remember to take a pill. So just thinking about lifestyle and what feels best for the patient, and also what the provider thinks might be a good administration method for them. So moving away from prescriptive methods for vaginal lubrication, thinking about lubricants. They are broadly categorized into water-based, silicone-based, and natural oils. And sometimes, of course, there are different brands that have mixtures of these. A water-based lubricant, I use ours as an example here, our lovely water-based lubricant. For the World Health Organization recommendations, they recommend pH neutral, which is roughly pH of a 4.5. Their osmolality recommendations are below 1200. So additionally, thinking about ingredients, glycerin, as you'll see on our label here, it's glycerin free. Something like 1 to 3% of the population is allergic to glycerin, and it can result in a burning sensation when they use it. So they have that allergy. Some don't know that they have that allergy until they try it, and it feels like a campfire happening inside their vaginal tissue. So just being mindful of the ingredients. It's important to find formulations that are glycerin, paraben, soy-free, and fragrance-free, no added fragrances for your patients. And then silicone-based lubricants, one thing that I'll touch on with water-based lubricants is with regards to sex toys or pelvic health tools, so things like dilators and wands, it's important to use a water-based lubricant with those because unfortunately, silicone-based lubricants don't play nice with the medical grade silicone on medical tools and on a lot of the toys found in the sex toy industry. It's just an interaction that they seem to have. So water-based lubricant or a natural oil. So for example, if a patient wanted to use coconut oil or avocado oil on our medical grade tools, they certainly could. And that would be their preference, and that works totally fine. So the only no-no is silicone-based lubricants. So silicone-based lubricants have a different slip to them. It can be sort of a patients report often a more sensual experience. It just feels a little bit more glidey. So it can be a good suggestion for intercourse. It tends to last longer, especially if the patient does experience a lot of vaginal dryness because they tend to absorb the water in the water-based lubricant and they have to reapply a little bit more often. Our formulation lasts quite a long time on the water-based, but for pleasure, depending on how their habits are. They are wanting something that's going to last a long time. Using a silicone-based lubricant is helpful, but again, not for use with medical grade silicone products. And there's a lot of different oil-based products on the market as well. As I mentioned, using like a pure coconut oil or avocado oil is totally fine. Some patients swear by them. They like that natural approach. There are pros and cons to using an oil-based lubricant, whether it's just a natural oil in its free form, like the coconut oil straight out of the jar situation, versus a formulated oil-based lubricant. So the pros include that it can provide a long-lasting glide. It's got, oil is oil. It doesn't dry out very quickly, and it can lead to less reapplication. It's got a natural feel. Some people enjoy, like on an avocado oil or an olive oil, that it's got that thicker natural slip to it. It can be moisturizing on the skin, and it's certainly a very natural and minimalist approach. The cons are that a lot of condoms save. So if that's part of their sexual planning protocol, then they should not be using oil-based lubricant. It can break down the latex. They risk breakage. It's also can be harder to clean. It can stain the sheets or their clothing or linger on the skin longer than they'd like. So they go to put their clothing back on and it can sort of get on their underwear or onto their pants. It can be disruptive to the vaginal balance. It could trap bacteria or yeast, potentially increasing the risk of infections. If they do suffer from chronic BV or other infections, probably oil-based is not the best method for them. Additionally, in some cases, it's not safe with silicone toys. So some of the oils can break down or degrade the toys. Our medical grade silicone, we have not had any reports of that with the natural oils thus far. Additionally, mess factor, it doesn't dissolve in water, so it can be a little bit harder to clean after the fact, whether it's the sheets or the clothing. They have to work a little bit harder to get that out and sometimes use like a stain remover. And then potential allergies. Nut allergies might be triggered if that's used, if they buy a formulated oil-based lubricant and they don't check very carefully if they've got a nut allergy and they are using like coconut oil or almond oil or those kinds of things, there could be a potential for an allergic reaction. Additionally, there are over-the-counter vaginal moisturizers. These are formulated and sold in different forms, generally in a gel. They are used internally in the vaginal tissue. It can also come in a suppository or a cream format. Important to keep an eye on those ingredients. Again, commonly they do use water or glycerin, and again, keeping in mind that 1 to 3% of the population is allergic to glycerin, and they might get a burning sensation and have an allergic reaction to that. So just alerting patients to that fact is really important. They may include hyaluronic acid, which is an ingredient that can help pull moisture to the surface. Keeping in mind that that does provide moisture to the surface of the vagina, but it is pulling from deeper resources. It's important that the patient does a good job of maintaining hydration, and that if they are using that a lot, they might find that the more they use it, the more they have to use it, sort of situation. So just being mindful of that. Other ingredients commonly are the almond, shea butters, sunflower oil. So just again, alerting patients that if they have a nut allergy, they want to keep an eye on those ingredient lists. And then often they include things to thicken it, like carbomer and xanthan gum, and then humectants such as propylene glycol. Then there are the external vulvar balms. Our particular formulation is And it's helpful for superficial dryness around the vulva and the perineum. It can be helpful for scar tissue after delivery, so postpartum, or those that are in that perimenopausal state and getting irritation of the vulva itself. Additionally, patients with lichen sclerosis or Sjogren's, as I mentioned at the beginning, or those with chemical sensitivities and they are getting irritation of that sensitive skin, or people who have environmental irritations, like when it's wintertime and their lips are chapped, the hands are chapped, there can be additional dryness in the vulvar area. But for this, it's used as needed. Ours is in a tub, as you see here. They just place it onto the vulvar tissue and perineum around the opening there and wherever else they like as needed. So if they're in a really dry state, I will recommend to patients that they keep it either in their bathroom if they're home all day or in their purse if they're out and about, and replace it on that vulvar tissue every time they wipe. So make sure they wash their hands before they go into the bathroom, go to the bathroom, wipe, replace the barrier, and then carry on with their day. And it's been a really nice one. So the nice thing about this is that it is organic. So if a patient is contraindicated for a hormone therapy for whatever reason, they can use this as a moisturizer of the vulva. And if they are on hormone therapy, this is not going to interfere. It's going on the outside. It's not going to affect how their body is absorbing in through the vaginal tissue if they're doing local estrogen therapy or systemic hormone therapy. So it's a crowd pleaser for all of those. Additionally, we have support here at Intimate Rose with telehealth services. If you have patients that are having trouble finding hormone support in their journey, we offer some hormone therapy online telehealth services. We also offer telehealth services for GLP-1s for those that are interested in that, with compassionate care providers that are working with those patients. And then for patients that are having trouble accessing pelvic therapy, whether it's physical or occupational therapy, we offer online support via telehealth for pelvic therapy as well. So we all know, as me as a clinician, I understand that one-on-one care is always gold standard. But for those that are having trouble getting in or having whatever barriers there are, we do offer those services for them. All right. Thank you so much for attending this. If you have additional questions, we are happy to answer them. You can email support@intimaterose.com. We can social platforms, Intimate Rose. I'm a Olson DPT as well. And we are always here for you. So thank you so much for attending, and I hope you have a great rest of your day.